Hi, everyone. Good morning. My name is Dr. Sameer Parikh. I am a hematologist at the Mayo Clinic in Rochester, Minnesota, and I am a member of the Medical Advisory Board of the CLL Society. And I'm here with Dr. Clare Sun, virtually joining in after the ASH meeting to discuss her abstract. I'd like to request Dr. Sun to introduce herself, please.
Hi, good morning, everyone. I'm Clare Sun. I'm a staff clinician at the National Heart, Lung, and Blood Institute in Bethesda, and great to be here.
Thank you very much, Dr. Sun, for taking the time to be with us today. We are going to discuss Dr. Sun's abstract titled Humoral and Cellular Immunogenicity of COVID-19 Vaccinations in Patients with CLL. So Dr. Sun, can you please tell us some more about the study?
Yeah, sure, of course. I think there has been, a lot of interest in vaccine response in CLL patients during the pandemic. In our CLL group at the NHLBI, we've been looking at vaccine responses for a few years now, initially to the influenza vaccine, and then more recently to hepatitis B and zoster vaccines. And then, right when the pandemic started was kind of when we wrapped that up. And so we've been collecting data on our patients who have been vaccinated against COVID. And this poster presentation was a preliminary analysis of the first batch of patients that we've analyzed so far. Most of our patients have received mRNA vaccine, over 95%. And so we looked at both the antibody and T cell responses in 58 patients with CLL. Over half of them were on active treatment, mostly on BTK inhibitors. They were either ibrutinib or acalabrutinib. We didn't have any ZANU or reversible BTK inhibitor patients. And when we looked at seroconversion, we used the FDA EUA Roche Alexis assay. And we saw that the seroconversion rate was 71% in treatment-naive CLL patients and 55% in BTK inhibitor-treated patients, and even lower, 20% in patients receiving venetoclax, primarily in combination with anti-CD20 monoclonal antibody. So looking at these numbers, the seroconversion rate is a bit higher. Of course, the patient population might be different than what has previously been reported by other groups, including the Israeli group and the French group, where they saw BTK treated patients roughly in the seroconversion rate of around 20%. So the other aspect of our study was looking at T cell response, and we did this using the adaptive immunoseq assay. So it's a sequencing-based approach, which is in contrast to what I think most other groups have been looking at, which is a cytokine either release assay or maybe flow intracellular cytokine analysis. And so with the adaptive immunoseq approach, we're able to map out clonotypes by sequencing the T cell receptor repertoire. And we're able to map out which T cells specifically react to the spike protein. And what we found was that the response rate was about 50% or so. And interestingly, there didn't seem to be an association between T cell response and antibody response. And, for healthy individuals, the adaptive immune response is usually coordinated. So the T cell and the antibody response kind of go together, but we haven't teased out yet whether this is related to the disease itself or the treatment that kind of disconnects these two aspects of the immune response to vaccine.
Yeah, so, that's wonderful. I mean, I think this is very important work. So thank you very much for leading this work. Patients always ask this question, that, it looks like the antibody response was not there, but maybe a T cell response was there, or vice versa. is this something that is now routinely done in the clinics, or if a patient wants to go to their local doctor and ask for these tests, are these available? Or how would you advise patients to go about doing this?
Yeah, I wish we had a standardized assay for T cell response to COVID vaccines, but unfortunately, we really don't at this point. As I mentioned, other groups have used different assays to assess T cell response as well. So right now, I think we're still in the research and data collection phase, trying to understand whether patients mount T cell responses at all. But I think it remains to be seen whether that offers protection in the absence of an antibody response.
Sure. I think there are now recommendations that a fourth dose should be administered to patients with an immune-compromised status, much like our CLL patient population. Are you aware of any studies or any data that have been published with respect to the third dose or the possible fourth dose of an mRNA vaccine in this group of patients?
Yeah, so I think with the fourth dose, that's something that's very new, and I think it's being implemented in Israel right now to certain populations. In the U.S., I think most patients are still just kind of finishing up their third dose and maybe not quite meeting the window where they would get a fourth dose. My sense is that most of the data coming out from vaccination reports or publications are kind of database collection rather than a prospective study, and that really has to do with how the vaccines are administered and regulated by public health authorities. So it'd be interesting to see, especially from the Israeli experience, what the fourth dose looks like, the response to the fourth dose looks like.
Sure, I think we're eagerly awaiting those data because I think it's important for us to know what to expect and what proportion of our patients, would really mount a response if they haven't had any response to the first 2 or even 3 doses of the COVID-19 vaccine. I have many patients in my practice who ask questions about, we have all seen multiple reports where treatment with venetoclax or even ibrutinib or other BTK inhibitors will not allow for a robust response to the vaccinations. And the question that is routinely asked is, would it make sense to hold ibrutinib or acalabrutinib for a short period of time, 4 to 6 weeks, to allow for the vaccine responses to happen? Are you aware of any studies, or are you aware of any data surrounding a topic like this?
Yeah, Samir, that's a great question. We get that question a lot as well in clinic, and there is no data right now to support that strategy to hold. And I think it's definitely worth investigating. The question is, how long to hold makes sense, right? We know that, at least in the approved BTK inhibitors, all irreversible. So the free BTK is basically generated. We don't, the kinetics of that varies from patient to patient. So it may depend on how quickly normal B cells recover their BTK. And also there are patients on BTKI where treatment interruption can cause tumor flare. So we discuss these with our patients in practice. Some have chosen to interrupt their BTKIs during the vaccine, especially if they didn't develop any response to the initial series. And we've seen some seroconversion in these instances, like very anecdotal, of course. But I think, there has to be a more coordinated effort to look at, what type of strategy makes sense to boost immunity in these patients.
Yeah, no, thank you for that. I agree. I think, our current sort of recommendations would also be similar, that, something like that should not be done outside the context of a clinical trial or some sort of a prospective fashion where patients are monitored regularly to make sure that their underlying CLL doesn't get out of control. So, is the study that you referred to today at the abstract presentation, is that still open? And if patients want to participate, how can they be a part of the study?
Yeah, it is. It is still open in the sense that, this is a part of our larger natural history study. So we have a study that's, I think it's over maybe 20 years now, the first iteration, but we've enrolled over 500 patients. We're actively following 300 who come to the NIH for their CLL, and they can be treatment naive patients or patients who are being treated outside by their local oncologist. And so the data that we presented at ASH was a sub-study of that, looking at vaccine responses. So that trial, the natural history trial, is still enrolling, and patients can, of course, reach out to us if they're interested in participating. We continue to collect data and blood to investigate vaccine responses now to the third dose, and as you alluded to, possibly the fourth dose in the future. And we're also, carefully annotating those patients who decide for various reasons to interrupt their CLL-directed therapy, so that we have a sense of, whether that will improve the immunogenicity of vaccines.
That's awesome. Thank you very much. Any final thoughts before we wrap up this session?
I just want to thank the CLL Society for kind of shining a light on vaccine responses in CLL patients. I think, we kind of, it hasn't been a very hot topic until this whole pandemic started, but I'm glad it's kind of, deserving getting the attention it finally deserves. Immunocompromised CLL patients, still have significant morbidity, mortality related to infections. And as the CLL-directed therapy is getting better, I think there should be, increased emphasis on figuring out ways to improve the immunocompetence of these patients. So.
Sounds very good. Well, thank you very much, Dr. Sun, for taking the time to discuss your abstract with us today. Congratulations again, and thank you.
All right, bye.